Break that word down. What's myelo mean? Marrow, right? Dis. What's dis mean? It's abnormal and plastic. It's like growth development, right? So if I broke that word down, what do I think that's going to be telling me?
Abnormal growth.
Marrow, the cells coming out of the marrow are abnormal growth or development, right? If I say myeloproliferative, what does that mean? Proliferative. It's growing lots of them, right? So I can just look at these words and start breaking them down. If I say myeloid cell line, what kind of cells am I thinking about?
Bone marrow.
RBCs, what else? Platelets, what type of WBCs? Granulocytes, like, so what are those? All your fills, right? And then if I say lymphoid, what am I thinking? T cells, B cells, and what else? Natural killer cells. And what's the difference between B cells and T cells? So B cells mature in the marrow, and they create antibodies, right? And then T cells are in the thymus, and what do? They target cancerous cells, infected cells, right? So if you understand these basics, it makes it a lot easier for oncology for breaking down these disorders. So we're talking about MDS. You'll also hear it called myelodysplastic neoplasms. So marrow disorders, right? We've already broken that down. This is characterized by defective hematopoiesis. What does that mean? What's hematopoiesis? That's the creation of cells, right? So predominantly older persons, 60 to 75 years old, right? So think about your patient population. These are going to be elderly patients. If you think about questions for tests. Key features are going to be abnormal blood and marrow cell morphology. That'll be talking about more when we talk about the labs. Cytopenia, what's cytopenia? Decrease, so if I say neutropenia, what does that mean? Decreased neutrophils. If I say leukopenia, decreased white blood cells, right? Leukocytes. If I say thrombocytopenia, all right, alright. And then risk of progression to acute myeloid leukemia, right? So if I say acute myeloid, what's a myeloid? What kind of cells are those? Which specifically? Myeloid cells. What? RBC, platelets, granulocytes, right? So if I look at AML, I can tell what kind of cells it's going to be affecting versus ALL. Then there's two types. We can say primary, which is spontaneous mutations in stem cells, and then secondary, that's exposure to DNA damaging agents such as chemotherapy, radiation, so therapy related to MDM. This may be a patient that had cancer in the past and was treated with some of those agents, and now they're developing these symptoms later on in life. Or potentially it's a hospital worker that was exposed to some of these, or somebody who works around nuclear power. Think about Chernobyl or the one in Japan. Often this is going to be an incidental finding on cytopenia, right? So you think about our patient population, what happens when we're like 70, 75 years old, just in general. Think about our grandparents, our parents. Things start slowing down, right? Lower testosterone, women are slowing down, so what are their kind of common complaints? I don't have as much energy as I used to, my libido's down, energy's down, right? And so if a patient comes in, 70-year-old, I hate when 70-year-olds come in there with fatigue, because it could be anything and everything, right? So this may be, you order the baseline labs, right? You order some thyroid panel, CBC, CMP, and you're thinking, hey, this could be hypothyroidism. If it's a guy, you get a testosterone panel. You get that CBC because you're looking for anemia. You might find cytopenia, just one cell line, or you may find pancytopenia, all three cell lines, right? So it's incidental finding. Anemia, they're all going to present kind of similar, right? Fatigue, pallor, just kind of nondescript. Thrombocytopenia, right? Low platelets, they're going to have bleeding, bruising, nosebleeds, gingival bleeding, right? They're brushing their teeth. They cut themselves and it doesn't stop as quick as it used to. Leukopenia, recurrent infections. Physical exams often unremarkable. Sometimes you may see splenomegaly or hepatomegaly, right? But that can be masked by other things too. If they're obese, you may not be able to find that on a physical exam. Vast majority of these, 85% of cases, is going to be affecting the RBCs, so they're going to be anemic. And then from there, it's going to be neutropenia, so neutrophils, white blood cells. Thrombocytopenia, 25% of those. If we look at bone marrow biopsy, this is a key exam here. So hypercellular, which means there's more of those blood-generating products in the marrow. And increased blast. What's a typical blast count on a bone marrow biopsy for a healthy person? Less than 5%, right? So 4% or below. 5 to 19%, we're thinking myelodysplastic neoplasms. If it's greater than 20%, what are we thinking? We're thinking leukemia, right? AML. So that's why we talked about previously there's an increased risk for it. So you could almost think like this is a precursor to AML. You could. We're just talking about general right now because it's the most common thing. But typically, if you see greater than 20%, we're thinking AML, leukemia, right? And so this is kind of a precursor to that, and you're going to see that throughout this lecture, is that there's an increased risk for the transitioning to leukemia if we don't catch it early on and we don't start treating it. Suspect that any patient with unexplained cytopenias or clinical manifestations associated with cytopenias, right? So what I tell you, if you get that CBC and you see pancytopenia, what's the first thing I want you to think? It's cancer until proven otherwise. All right? So I've already written this test, and I'm just going to tell you up front. This WHO diagnostic criteria, this is not testable. This is more so for you to understand. It is important to understand, but there's not going to be like specific questions like what is the WHO diagnostic criteria for AML or anything like that on the test. But it does help you with the diagnosis, with the definition of what these diseases are. So don't completely write it off. Management's going to be tailored specifically to what cytopenia severity is, right? So if it's RBCs, we may be looking at some type of agent to generate more, like an EPO agent, right? Or transfusions if necessary, or versus platelets. The risk of AML progression, right? So if we have that bone marrow biopsy and we see that it's 15% blast right now, we had a bone marrow biopsy from 2 years, we're kind of tracking this patient because it's slowly progressing and it was 5%, then maybe put in increased risk for AML progression, so we may be more aggressive with our treatment protocol. Also, patient age performance status, right? So this is a slow progressing disease. You have an 85-year-old that you diagnosed. Aggressive treatment may not be indicated. They may not want to pursue that. They may not want to be undergoing that. The quality of life for the last 5 to 10 years of their life, they may want to focus on that versus curative options. Treatments, right? So supportive, transfusions as indicated. Those ESAs, the EPO and the TPO to help with creating platelets and RBCs. Immunosuppressive therapies as indicated. High-risk cases are going to be chemotherapy or hematopoietic stem cell transplants. So that may not be an option if somebody's older if they don't have a viable donor. Prognosis varied wildly depending on the subtype and the risk stratification. But a lot of these patients, you may identify these, continue to monitor them. Their cell lines aren't significantly decreased, so you may be able to do 6-month, 12-month follow-ups. But all these patients are going to be getting referred to hematology if you find them. Hematology oncology. So typically when you put a referral, it's going to be hematology oncology. Now when you get to somewhere bigger like BAMC, right, like an academic institution or research institution, they may have like different subtypes. If you're going to like a traditional medical center or smaller hospital like MTF in the military, it'll just be Heme, kind of a one-all catch-all, and then they'll suffer fur out. But if you go to BAMC, they may have like pediatric oncology, they may have benign hematology, initial hematology oncology clinic, they'll have those different variants. The myeloproliferative neoplasms, right? What's proliferative mean? Lots of them, right? So, this is clonal abnormalities of those hematopoietic stem cells leading to an excess production of blood cells. And again, the myeloid cell lines, what's myeloid going to be? RBCs, platelets, and what else? Monocytes, granulocytes, neutrophils, and eosinophils. And then the four we're going to be talking about, myelofibrosis. What's fibrosis? Just think scarring, right? Polycythemia vera, that's one of those diseases. Very interesting one, but central thrombocytopenia, or central thrombocytosis, right? What's essential mean? Right, it could be another word for idiopathic or just there, right? What thrombocytosis mean? Lots of platelets, right? Elevated platelets. CML could be a myeloproliferative neoplasm, but it also causes leukemia. We're not going to talk about it in great depth today. We're just going to briefly mention it, and we're going to talk more about it in regards to the leukemia lecture. As far as the pathophysiology, right, with tyrosine kinase, right, those are those on-off switches for the cell growth and development, right? So if those are mutated or have issues with them, now you're having that proliferation of cell lines, right? For testing purposes, just know that this is the on-off switch. I'm not going to ask you specific mutations necessarily on the test. That's not going to be an answer for anything. But do know what these are signaling, right? It's responsible for cell division. If I turn those mutations off, or I have mutations, it's going to turn on those receptors, so now you have overproliferation, nothing's stopping them. So myelofibrosis. So excessive fibrosis in the bone marrow. So we talked about what's fibrosis, it's scarring. So if I have scarring in the marrow, what's not happening? You're not creating those cells, right? So myeloid cells, specifically those RBCs, platelets, and some of those WBCs. So what's going to happen? What does the body do if it can't, the marrow's not producing blood? It's going to be the liver and spleen, right? So that extramedullary hematopoiesis, right? This is a key portion of myelofibrosis. So you have these megakaryocyte growth factors causing bone marrow fibrosis. Megakaryocyte, what's that, a precursor for what? For platelets, right? So that's going to be causing this excessive bone marrow fibrosis, right? The healthy tissue is being replaced with the scar tissue. So now it's not producing, so the body's saying, hey, we still need all this stuff. So it's going to make it in the liver and spleen, which, if those are working overtime, what do you think is going to happen to them?
Hypertrophy?
Yeah, they're going to become larger, right? Overuse. And again, it's these mutations. You're having overproliferation. In this case, it's the megakaryocyte growth factors that are causing this. So the fibroblast growth factors cause megakaryocytes to stimulate fibroblasts to produce collagen. The collagen starts replacing the healthy tissue. You start getting fibrosis. Extramedullary hematopoiesis, right? Spleen, liver, splenomegaly, and hepatomegaly. If I said these two, what kind of symptoms are your patients going to have? Their liver's enlarged and their spleen's enlarged. What are they going to start complaining about?
Bloating?
Bloating, abdominal fullness, right? What about when they eat? Early satiety, right? So they're getting full early. So think about that with your patient and that pathophysiology, right? Their bone marrow is failing. So now their liver and spleen are having to kick in to do the extra work. Can they keep up with production in comparison to the marrow?
No.
No, they can only do like 10% maybe at most in relation to that. So they're not going to be able to keep up. So they're going to work overtime. They're going to get larger. So that patient's going to come in with these vague symptoms, right? They're going to have symptoms of saying, hey, I'm just feeling like very full. It doesn't matter what I eat. It doesn't matter what I do, what position, I just feel full. And then when I eat, as soon as I eat, I feel full. I can't get a full meal in because I'm just getting filled so quickly. And then this is looking at that big old spleen right there, right? So are you gonna be able to palpate this?
Yes.
Yeah, but sometimes, honestly, they're so large that you're not really 100% sure what you're palpating. You go to feel it, you're just like, maybe this person's pregnant, but it's a 60-year-old man, this doesn't make sense. You're gonna have this large mass. And then that liver, you're probably gonna be able to palpate that. You'll probably, if it's a skinny person, you'll probably actually see him poking out from underneath that rib cage. Probably gonna be pretty firm too. So if I have a large liver, what else is that gonna push on or cause? Now that portal hypertension, which is gonna lead to what? Sinuses, right? Think about all this stuff. But early on, they may be asymptomatic. So this is gonna be a much later finding. This isn't something that acutely happened. This spleen being this big. This is over weeks, months, maybe years. But very common too with these is gonna be fatigue. They're gonna be extremely tired, and then they're gonna complain about this abdominal fullness and early satiety, right? So I want you to understand that these are key characteristic findings of this one. Patient's very tired, abdominal fullness, and then night sweats, weight loss. What kind of symptoms are these? Those V symptoms, right? Late disease, you're going to start seeing severe anemia, bone pain, and portal hypertension. Why are they getting that bone pain? All that scarring, right? They're getting infarcts in their bone, and so it's very painful to them. And then that portal hypertension is caused by what? It's that liver, right? It's being enlarged, so you're going to start getting ascites. It looks like that pregnant man, right? You tap their abdomen, you get all that fluid off. And then what are varices? Are those going to be external, internal?
Esophageal.
So it could be both, right? You could have esophageal varices, you could have it on the other places as well too. But you're going to have that hypertension or that portal hypertension causing that. Laboratory findings, decreased hemoglobin hematocrit, WC, and platelet counts variable depending on the etiology. Poikilocytosis, I feel like that's Hawaiian, right? But it's red blood cells of varying shapes. Dacrocytes is those teardrop shapes, right? So you may see that, giant platelets with abnormal morphology. And then that leukoerythroblastic blood, immature WBCs, immature nucleated RBCs. So if you see blast, what are you thinking? Anytime blast. Immature cells, right? So blast, immature cells. Bone marrow biopsy, of course you're going to need this, right? Because this is affecting the bone marrow. And we're going to require that for definitive diagnosis. So myelofibrosis, myelo being the marrow, right? It demonstrates fibrosis with markedly increased reticulin or collagen fibers or marrow cellularity, right? We talked about those megakaryocytes are causing the increased collagen, increasing the fibrosis, destruction of that healthy tissue. And then others, not always, is going to be accompanied by those mutations that we talked about, right? So those tyrosine kinase, the on switches. Treatment for asymptomatic patients that you catch early on, observation and supportive care as necessary. We may not need to intervene. The treatment may be worse than the actual disease of this process. Transfusions, reserved for severe anemia. And then hydroxyurea, what kind of medication is this? It's an oral chemotherapy agent, right? And so what other disease that we talked about in hematology that we prescribe this for? Sickle cell, right? You're going to see this medication a lot throughout oncology. It's a common first-line agent. It's been around for a while. Great uses. But that's going to help with reduction of that spleen size and it will decrease some of those cell lines as well too. Less so in myelofibrosis, but in sickle cell you can actually see regrowth of the spleen, where it actually, spleen will go down initially, but as we increase the blood flow to it, you can actually start to see that spleen go back up in size, kind of this proximal growth to it. Splenectomy, maybe if they're not responding to that hydroxyurea, right, that's going to be secondary to that, is that they are having this medication refractory splenic enlargement, painful episodes due to splenic infarcts. They're overworking because there's so many RBCs or platelets it's trying to process. So you may start getting that. Or severe thrombocytopenia, we need to slow down that process of platelets being destroyed. So again, that's not a first-line therapy or first-line option. It's typically after they've not responded to therapies. Those JAK2 inhibitors, so that's actually controlling those mutations for the on-off switches for that cell division, so that may be appropriate too if they're not responding to these other medications. You may see that also be as an adjunct to the hydroxyurea if they're not responding to that initial treatment before they do any type of surgical options. Curative, those allogeneic stem cell transplants, right? So again, you need to find appropriate donor, costs a lot of money, so it may not be available for all of our patients. And then all these patients are going to be going to hematology. There's your prognosis. Everybody understand what the 5-year survival rate is, or 10-year survival rate? So the percentage of patients still alive at the end of that 5 years. So that is not 100% because there's a lot of factors that go in there, right? If I say the 5% survival rate of this cancer is 20%, but I'm including a 20-year-old who's healthy without any comorbidities versus a 80-year-old COPD patient with uncontrolled diabetes, right? They're not equal. So you got to take it with a grain of salt when we use that grading and staging and the whole package, the patient as a whole, to do that. So don't get wrapped around those 5-year and 10-year survival rates as being the end-all be-all. But you can also see them adjusted for healthy age and sex match controls, which may be a little bit more accurate. But again, those don't account for all comorbidities and everything else going on with the patient. But mortality is often due to infection, liver failure, bleeding, or transformation to that acute leukemia. Polycythemia vera, right? This one's the easy one to remember. It's thick blood, right? It's too much of everything. Yeah, it's very distinct physical exam findings that we're going to talk about. So, overproduction of RBCs, WBCs, and platelets. RBCs are going to be the most predominant feature of this. And again, it's another mutation that on-off for cell growth, cell delineation, proliferation. Cells are just going uncontrollably. Hyperviscosity, right? Too much of something, right? What is pruritus aquagenic? How would that be described like in a question? Yeah, so a patient doesn't want to take a shower because they get very itchy, right? Especially with hot water. They take that and they're like, I hate taking showers now. I get super itchy. No matter what I do, it may be a little less with cold showers. But if that patient is describing an itchy sensation, this in San Antonio, the first thing I would probably say is you have hard water, right? You need to get a water softener. But in this case, this is going to be a very specific finding. Plethora, what is plethora? It's a lot of, it's that red ruddiness of their face. And we have a picture here we'll show in a second. Splenomegaly, thrombosis, paradoxical bleeding. What's paradoxical bleeding? Have you heard this term before? So this is despite too much platelets, too much RBCs, they still have bleeding even though they're hypercoagulable state, right? If you have too many platelets, that makes you hypercoagulable. But what's happening in this is there's so many platelets, they're consuming all the clotting factors, so now you have excess platelets that contribute to excess bleeding, right? So they're consuming all that, so they can have a hypercoagulable state and still be bleeding. You need age of presentation, again, 60 or every 40, so we're thinking all these diseases for the most part are elderly, 60 and above. You're going to see elevated hematocrit, and then what's EPO? Where is that made? Kidneys, and what is it? Yeah, so we have suppressed EPO. Why we have suppressed EPO is the body's no longer responding to EPO because the marrow is just making excess RBCs regardless. So it basically just doesn't matter anymore, so it suppresses that EPO. So you're going to see decreased EPO on labs as well. You're going to confirm it with that JAK2 mutation, right? That's that tyrosine kinase mutation, that on-off. A lot of these are going to be discovered incidentally. The patient may have these vague symptoms with physical exam findings. And there's plethora, right? What else could that look like? The patient just comes in and they have like these vague, like, kind of fatigue.
Lupus?
Lupus? So lupus has more of the classic butterfly. It's not going to be the full face. If I'm being honest, man, I grew up in the South. Like this guy looks like he was ridden hard and hung up wet. You never heard that term, right? Looks like he just had a tough life, man. Sunburned. My grandfather never would wear sunblock, right? So this may not be the first time I'm thinking of plethora as some type of hematological disorder if I had this guy walking in here. But if I start putting this together, we're going to have enlargement, redness of those conjunctivals, so his eyes are going to be red. Erythromyalgia, what is that? It's that painful burning sensation of their hands, accompanied by erythema, so no matter what they do, their hands just feel like they're burning. Splenomegaly, right, palpable in 75% of the cases. So that's going to be a physical exam you're probably going to find on this patient. Symptoms related to thrombosis, what would those be? What's that? By strokes, maybe like parts of their hands. What's that? DVTs.
Recurrent DVT.
All right. Superficial thrombophlebitis, right? That very kind of superficial stuff on their extremities. And then that paradoxical bleeding that we talked about. Acquired von Willebrand syndrome is where you have these large von Willebrand factors that aren't being broken down. And so it's increasing this ability to bleed. And the peptic ulcer disease. Hallmark for this, so this is going to be all of your cell lines are elevated, right? So this is an easy one, like DIC, everything's wrong with this one, everything's going to be elevated, right? So you're going to have elevated hemoglobin and hematocrit, elevated platelets, elevated white blood cells, then iron deficiency anemia, right? So they could still have that paradoxical bleeding, so they could still have a GI bleed, right? So if you see anybody over the age of 60 with iron deficiency anemia, what do you need to be thinking? They have an occult bleed, a GI bleed, possibly a malignancy, right? So have a high index of suspicion for iron deficiency anemia, especially new onset in these elderly patients. We already talked about that EPO being suppressed because now their marrow is just creating all these RBCs. It's no longer responding to those typical signals. Why would we have elevated uric acid levels? Right? It's a high turnover of all those RBCs being destroyed, being released into the system, right? RBCs, the hemolysis, they get destroyed, and it's more than the body usually can regulate or control on a regular basis. So now you're getting increased uric acid levels. And then serum iron levels, why would they be decreased? Yeah, it's proliferation disease, right? So that makes sense. It's myeloproliferative, right? So the body needs all this iron because it's in this constant state of creating more RBCs, more platelets, everything. So it's using all that iron up. So that kind of makes sense why we'd have decreased iron levels. But then typically the CBC is going to be sufficient to make your neutral. You don't need a bone marrow biopsy for this. It still may be indicated if you're working it up for hematology. But typically it's not needed for the diagnosis, but they may order it to rule out secondary causes or some underlying issue. And then again, it's going to be a genetic mutation that's causing this. That on-off switch is broken, so now it's just stuck on. The mainstay of therapy is going to be phlebotomy. The mainstay of therapy is going to be phlebotomy. Mainstay of therapy, right? Antihistamines to help out with the pruritus. And then what kind of pruritus is this? Aquagenic. So how would that patient present? Itchy. So now I want you guys, when you go to the gym or you go to the gym on base, you see that old man and their old lady showering in the shower. You're going to go up to them and be like, I think you may have polycythemia vera, and then you're going to run out. Don't do that. That's going to be creepy as hell if you do that. But some of these old guys have no shame in their game when they're in the gym. They'll just pop that leg up, butt naked. I'm like, all right, man. I don't need to do an exam on you right now. This is just getting weird. Allopurinol for those uric acid levels, and again, why are the uric acid levels increased? It's all that turnover of RBCs, right? They're just this proliferation. They're creating so many of them, they're getting destroyed. Low dose aspirin prevent that thrombosis because they are hyperviscous, right? They have all these RBCs, platelets, all this thick blood. High risk cases is going to be that hydroxyuria. We've already talked about that, right? see that a lot in this, in oncology. So that's primarily for our high-risk features, right? So understand that high-risk features, age greater than 60 and or a history of thrombosis. They have a high phlebotomy requirement, thrombocytosis, intractable pruritus. So think about, yep.
The hydroxyurea, it says chemo drug, it helps the spleen, but what's it actually?
Suppressing the blood cell lines, the myeloid, so it's decreasing the production of those. So, you guys heard about social determinants of health? What are some of those?
Money.
Money, right? Economics, right? So, education, access to healthcare, right? Access to health insurance. So think about that with some of our patients, right? High phlebotomy, right? If somebody has to go to the hospital once a week to get blood drawn and go through that procedure, is that going to impact them?
Yes.
So consider that with your patients, right? That may be a barrier to care of why they're not seeking care. If they live in the middle of nowhere, rural Missouri, do they have access to that? Right? It may take them 2 or 3 hours to get to Kansas City or St. Louis to get this treatment. So barriers to care, some of this stuff sounds pretty straightforward. Well, you should go get some bloodletting done, right? But it's not like back in the days where the guy just came with a knife and did some bloodletting on you. But these are barriers to care of why. On the surface, this is like, hey, this should be a very easily managed disease. It may not be so easily managed because of this stuff, right? Same thing with warfarin. What does warfarin require? Monitoring requires regular labs, right? So sometimes you got to figure that out. What's the most appropriate treatment for this patient? What do they have access to? Hydroxyurea, we're going to do dosage adjusted to keep those platelets less than 500,000 without reducing the neutrophil count, because this is going to affect all of them. So it's kind of, we're finding that happy balance. And if they are resistant or intolerant to hydroxyurea, you may use that JAK2 inhibitor, right? Or it may be used as an adjunct too. That's going to be determined by hematology or oncology. There's your prognosis. So median survival greater than 15 years. For patients that are routinely getting treatment and they are following up, they have better life expectancies. These people that aren't getting this care or aren't taking their aspirin or taking these meds, now they're at risk of arterial thrombosis, right? And over time, if this isn't managed, that may convert to that myelofibrosis that we talked about, that or that CML. And how many blasts are we expecting to see with leukemias? Greater than 20%, right? Central thrombocythemia, right? So this is excess platelets, too many platelets. Literature of megakaryocytes in the bone marrow, the platelet count is greater than 450, right? For this ET, platelet count greater than 450, right? That is going to be the key to this diagnosis for this disease. Often asymptomatic, right? You may find it secondary after they've had a clot or some other disorder, but a lot of times this is going to be that patient that you're running routine labs on, and you get a CBC and you see, hey, platelet count is super elevated. What's the cause of this? But you may be also seeing it during the workup following a thrombolytic event, right? They throw some type of clot in a weird place, and you're doing that workup, and you're seeing that, hey, clotting factors are normal, but they have a lot of platelets. And then that JAK2 mutation is 50% of the cases, but there's also secondary causes that may be causing that. Most are asymptomatic, female. Again, look at that age. So these myeloproliferative disorders are going to be the elderly, greater than 50 or 60 years old. And then include maybe they had some thrombosis, mesenteric, right? They have this atypical abdominal pain. Get a CT or MRI and you find that on there. Portal or hepatic, somewhere in their liver, right upper quadrant. They may also have this mucosal bleeding. It's less common. Nosebleeds, mouth bleeds, or brushing their teeth. They have a little bit of rectal bleeding. Splenomegaly is less common, 25% of patients, because this is just platelets and not RBCs as well. And there's where we talked about with that burning hands, right? Libido reticularis. What else could cause this? I saw this in the ER one time when I was a student, and I was like, oh shit, this person's got ET, So I worked it up, and I think the ER physician was laughing at me, like, it doesn't have that. Probably a person just has cold hands or exposed to something. Yeah, their platelets were normal, but I thought I had a slam dunk. So this isn't specific just for this, but you may see it in conjunction with that. So this alone is not diagnostic or a hallmark finding, but you will see it in conjunction with these other findings. But platelet count is going to be increased. That is the key diagnostic finding on this. And hematocrit is going to be normal. WBC's mildly elevated or normal. Peripheral blood smear is going to be normal. The absence of Philadelphia chromosome, right? Where do we see Philadelphia chromosome? We're going to talk more about it in leukemia, but it is the hallmark finding of CML and then sometimes in AML too as well. But I promise you, you're going to see Philadelphia chromosome every time I've taken the pan rate in PANS. And I was just talking with Colonel Douglas. It's a joke, but there's usually like 6% of the PANS or the pan rate is hematology oncology. Guarantee this is always going to be a question, is Philadelphia chromosome. Any test you take on hematology oncology, Philadelphia chromosome is going to be an answer. So if you didn't hear something, I just, damn, put it on the bottom of my shoe. Right, and then bone marrow biopsy, you're going to increase megakaryocytes. Why would we see increased megakaryocytes? Yeah, there's a precursor to platelets, right? Right, hydroxyurea to control platelets, keep the platelet count below 500,000. What is the normal range for platelets? 450, right? Aspirin for those warm hands. JAK2 inhibitor, if they're not responding to the hydroxyurea or in conjunction, all these go to hematology as well. Typically, once you make the diagnosis, you're managing your patient, they have a normal life expectancy, very low risk of transformation to AML, but a higher risk of transformation to myelofibrosis if we don't get under control. CML, again, we're just going to talk about this briefly. BCR ABL1 fusion gene, that is our Philadelphia chromosome. This is going to be elderly, right? So CML, if I say myelogenous, what is that going to be affecting? What kind of cells? Myeloid stem cell lines, what are those? I want to beat this into you, man. Like this, I got to keep beating this. What are myeloid stem cells? Say it loud, say it proud. RBCs, platelets, what else? Radiolocytes, right? So, fatigue, weight loss, what are those symptoms again? These symptoms, right? Splenomegaly, leukocytosis. So when we talk about leukemias, we're really focused on the white blood cells. The leukocytosis, greater 100,000. We're going to be going much more depth about CML tomorrow, but this is unique as it has this triphasic, which we'll talk more about. Chronic phase, accelerated blast crisis. When I say leukocytosis with left shift, what am I talking about? Left shift is what? Right, you want to sound smart on round, you're going to say, I see, take your glasses off slowly, a left shift, right? Instead of saying, I see increased neutrophils, you're going to say left shift, right? And then that fusion gene, PCR for this, Philadelphia chromosome. What test are you going to see this on? Any hematology oncology test you ever take, you're going to see it on the PANS. You guys will be PAs for a while. Every time you take the pan read, and you're going to get pissed off because you got to pay this money every year, every few years for this pan read, take the stupid test. Even if you work in dermatology for 25 years, you're going to have to relearn primary care and relearn all this OBGYN stuff. And you're like, this is why I got into orthopedics. This is why I did this, so I didn't have to remember this. But every time you're going to see Philadelphia chromosome, think CML. All right, here's a summary. Myelodysplastic, right, it's defective hematopoiesis, so we can't make those cells. That's going to be 5 to 19% blast. Greater than 20% blast, what are we thinking? AML, right? So we get that bone marrow biopsy. Less than 5% is normal. 5 to 19%. Thinking myelodysplastic. Greater than 20, we're thinking AML. Then we have those myeloproliferative neoplasms. What's proliferative mean? Excess, right? So the myelofibrosis, how's that patient going to present? Abdominal fullness, so what are they going to say when they eat?
Can't finish
Yeah,
a meal.
can't eat, they get early satiety, right? That's caused by that what? Which is caused by what type of extramedullary hematuria? All right. Polycythemia vera, right? That is what? All three blood cell lines are up. White blood cells, platelets, and RBCs. And what's the treatment of choice for this one? Phlebotomy, man. If you guys missed that. I always put Rasputin on the test, but then I was like, man, I'm going to get called out by somebody, like an instructor or something, for putting that. You may see it on this test, I don't know. Central thrombocytosis. With thrombocytosis? High platelets, right? They're increased risk for thrombosis. And then what is this little gene right here called?
Philadelphia.
All right, think Elton John. Philadelphia freedom. I'm going to refer all these to hematology as well. All right, there's a nice little chart. All right, so let's take 5, and then we're just going to get into the acute, and then tomorrow we'll finish off with the chronics. So there'll be quite a few questions from this. The reality of it is PANS and PANRE. You're going to see majority of the stuff. Promise you on your PANS, you're going to see at least one iron deficiency anemia question. You're going to see a macrocytic about vitamin B12 or folate, and you're going to see at least 2 or 3 leukemia questions on your PANS. We don't see that much in clinical practice, but for some reason they think that primary care is just like drowning in leukemias. The CCPA does. Don't know why. All right, so I like this slide because it breaks it down pretty easily, right? There's some general rules about leukemia that if you understand. So, excess production of abnormal white blood cells, all right, we all understand that. Now we look at acute versus chronic. Acute, rapid onset, chronic, gradual onset, right? Acute, progress quickly if untreated, right? So these patients present, these are rapid onset of symptoms. This is going to be immature cells, those blasts, right? So greater than 20% blasts for acute process. So if I say lymphoid, what kind of cells am I talking about? T cells, B cells, natural killer cells, right? If I say myeloid, neutrophils, monocytes, RBCs, platelets, right? So again, if I say acute lymphoblastic leukemia,
Battery finally died.
it's greater than 20%. If I say chronic, it's going to be gradual onset. This may have been going on for years. And it's going to be mature cells. And then if I say lymphoid or myeloid, understand what I'm talking about, right? It makes it breaking this down a lot easier. There's the 4 main types that we're going to talk about: AML, ALL, CML, and CLL. We're going to be talking about the acute ones today. AML and CLL are the most common in adults. ALL most common in children. I know it's kind of messed up, but I always remember all children have leukemia. It's horrible to say, but that's how I remembered it, to understand that, because you're going to get a PANS question, and the answer is going to be ALL, and it's going to be a pediatric patient. What kind of leukemia do they have? And then CML, median age is 55, so we're going to be the elderly. And then what type of mutation am I going to see in CML? Philadelphia. All right, there's a nice little picture. So AML, the elderly. ALL would be pediatric patients. So clonal proliferation of myeloid precursors with failure to mature, right? So it's going to be mature cells or their failure to mature. Accumulation of abnormal leukocytic blast cells, those myeloid precursors, and what are the myeloid cells? Monocytes, neutrophils, right? Power rods, is that how you say that? All right, I'm not a loud person. So that's going to be a distinct finding for AML, power rods. right? I'll talk more about that, but if you see these rods, I want you to think AML. You see Philadelphia chromosome, what do I want you to think?
CML.
CML. Caveat to that, you can also see Philadelphia chromosome in another one we'll talk about. But I still want you to think CML. Impaired production of normal blood cells. You're also going to see in conjunction with that is anemia and thrombocytopenia, so decreased RBC, decreased platelets. There's a nice little trend for AML, right? Median age is 68. With ALL, it's going to be the exact opposite. This is the most common acute leukemia in adults. Most common acute anemia or leukemia in adults. It's going to be AML. Prior chemotherapy, radiation, right? So that vignette, that patient question may be, hey, patient is in remission for breast cancer that they got treated for 20 years ago, and now they're presenting with this abnormal CBC, 20 to that. Prior chemotherapy, radiation, right? Environmental toxins, benzene, where do we see benzene? What kind of workers? What kind of factory workers? So you're gonna see like in plastics, people working like in plastic moldings or resins, stuff like that, so benzene. So think about a factory worker that was exposed around that. You can also see it in what else? See it in cigarettes, right? You can see it in burning trash. So is that another thing? Like burn pit registries, right? So that was like a bane of my existence for about 2 years when I was working in Africa. I was trying to get burn pit, like for the Prep Med people and everybody to do burn pit evaluations. And I kept hearing from SOCAF, AFRICOM, Big Army, Medcon, well, we won't do the evaluation unless we're the ones burning the trash. Well, I already know what we're burning. I'm concerned more so about the guy next to us who's burning it. So they would never pay for that. So we'll see if these burn pit registries, because we burned a lot of plastic and a lot of other stuff. If you're ever in Afghanistan, you probably are exposed to that as well too. Genetic predisposition, so Down syndrome, higher likelihood of developing AML as well. Then clinical presentations, again, those cytopenias, right? So cytopenias, we specifically think about RBCs, that anemia. So they're going to have that fatigue, pallor, dyspnea, very generic, kind of vague symptoms. Thrombocytopenia, bleeding, petechiae purpura, right? So hopefully this course is teaching you to like take the exam seriously when you're looking at somebody's mouth. Like don't overlook that stuff. Like actually take the time, especially elderly patients. They may not have the best oral care. They may not be checking these things. So take the time to actually put your hands in their mouth, lift up their tongue, look at the roof of their mouth, check along their gum line because you may be missing stuff. Neutropenia, recurrent infections, fever, and then specific features, that gum hypertrophy, right? See that in the bottom? What else would you see that in? See like young patients? What do like young people in the Army like to do? Dip, you may see that hypertrophy right there. Remember at Bragg, I was going to the dental clinic and I saw this kid in the 82nd walk out, and he obviously just had some dental surgery. And it kind of gave me, it was horrible to watch, but it also gave me like a confidence that maybe we have hope in the Army. Because he pulls out like his dental gauze and like just throws it on the ground, spits out blood, takes out a big dip, throws it in there, and takes his brain, does like that thing, and just kind of walks off pissed off. And I was like, all right, that kid's a warfighter, he's an idiot. But he will run through a brick wall for you. So hepatitis splenomegaly, right? So that enlarged liver and spleen you may see in some of these cases as well too. And then here's our lab findings. So again, those cytopenias, decreased RBCs, decreased white blood cells, decreased platelets, myoblasts, right? So this is a acute process, greater than 20%. Those rods, you see these rods, I want you to think AML, right? And this is what they are. Those granulocytes that are condensing right here and creating that. The bone marrow biopsy, hypercellular marrow, greater than 20%, right? Uric acid is increased because what? So increased turnover of those RBCs are being destroyed, right? So you're going to have increased that. Cytogenetics and flow cytometry, right? They're adjuncts for this diagnosis. I'm not going to ask you about these mutations for this test purposes. But if you go on an oncology rotation, you may see these exams. There's a WHO classification. So with recurrent genetic abnormalities, myelodysplastic related changes, which we just talked about, right? Therapy-related AML is what? Yes, a patient with prior exposure to chemotherapy or radiation, or somebody maybe occupational risk associated with that. AML not otherwise specified as idiopathic, right? When I was in school, like when we did clinical core, if I couldn't come up with a second differential diagnosis, I always would say idiopathic. Every once in a while you'll get an instructor who'll be like, I'll give it to you. But when you say like idiopathic hip pain, they're like, no, you're just lazy, you don't know what you're talking about. But that was my catch-all for everything, was idiopathic. And then there's these other ones, myeloid proliferation related to Down syndrome. So again, Down syndrome is a higher likelihood of AML than without. There's not going to be, I'm not going to be asking you the type of chemotherapy of 7. You know 7+3 regimen, right? If you work in oncology, this stuff changes on a regular basis. So the PANCE is not really going to be focusing on chemotherapy because you're in a primary care setting. More so understanding the effects of chemotherapy, how you're going to manage that patient, and kind of expectations for how long this is going to take. And that it's not a straightforward, you know, just one size fits all. It's going to be different phases, right? We talked about that induction, that's the initial. Targeted therapies, more specific depending on what type of AML it is, and that consolidation. What's tumor lysis syndrome? We're going to talk more about this, but what is that? We talked about that increased uric acid level. What was that from? RBC, right? So tumor lysis syndrome is the destruction. You're going to see that with like a high dose chemotherapy, or potentially like the induction portion of that, where we destroy a bunch of cells pretty quickly. Body's not ready for it, so you get all those contents from those cells, whether it's cancer cells, RBCs, healthy cells. They get destroyed, they release their contents out into the body. Body can't reabsorb them or process them quick enough. And then you can get this acute kidney injury as well, and electrolyte abnormalities. We're going to talk more about that in oncology emergencies, but tumor lysis syndrome, I want you to think acute kidney injury and electrolyte imbalances, right? And that's caused from that chemotherapy destroying these cells and them releasing all their contents out into the body, and it causes these imbalances. Prognosis, variable based on age and cytogenetics, right? So there's different subtypes, so issues that cause that. But 5-year survival rate is 30% in older adults. Better outcomes in younger patients. And what was our average age for AML? Right, so older people. And we think ALL and what type of patients? Pediatric patients. And what was that distinct lab finding that I said that I want you to remember for AML? All right, you guys are on it. Recurrent genetic abnormalities. What I want you to get out of this is this APL with MLR. We're going to talk more about that. The acute promyelogenic leukemia, granulocytic leukemia. So 5 to 20% of all cases. This is by promyelocytes, so cells are slightly more mature than true blast. They're kind of one step up. What I want you to get out of this is DIC is common. So these patients are increased risk for DIC, for APL, right? That's because those cells are slightly more mature than blast, and they predispose the patient to coagulopathy because of those procoagulant substances, right? So APL, I want you to think DIC. And how do we diagnose DIC? All the labs are abnormal. How would that patient with DIC present?
Bleeding, throwing clots.
Bleeding from sites, right? So they have signs of thrombosis because they're consuming all those clotting factors of platelets and they're bleeding. So where would you see bleeding from?
Injection sites.
These sites. Nose. You ever see that movie Outbreak? Or that where your blood's coming out like random places? DIC, and then all the labs are wrong, right? So they're having signs of increased bleeding time, but they're also having increased D-dimer. All that stuff is going on. So all the labs are wrong. DIC, APL. So Therapy-related AML, that aggressive form, right? This is months to years after chemoradiation, so the key is going to be that patient's history. They have they're in recovery for remission for this type of cancer. They had exposure to chemotherapy or radiation, right? Lesser likelihood they could also have exposure from occupational risk. We're pretty good at that in America of managing that stuff. So we're seeing that less often, but it is still a risk. What I want you to get out of this is you don't need to know these these example given, these actual agents, but understand what they're being treated for and generalize. Alkylating agents, latency 5 to 7 years, right? So versus this one down here, treats all tumors 1 to 3 years. All right, so just have a idea. You don't have to know specific agents, what it's being treated for, and then the time periods that you're going there. But have a high index of suspicion if you have a patient that has a history of cancer, they got treated with chemotherapy, radiation, and now they're presenting with that abnormal CBC. You need to work them up and be aggressive with them. All right, ALL, who do we think for this patient population?
Children.
Children, right? All kids have leukemia, 4%. Malignant transformation of lymphoid. So we'll talk about B cell and T cells and what's the difference between the B cell and T cell. B cell is where? Where does it mature? The bone marrow, and what does it do? It creates those antibodies, right? And what's our T cells? Where does it mature? Thymus, and what does it do? Yeah, it directly attacks, right? So it kills those infected cells or cancerous cells. This proliferation or accumulation of those clonal blast cells in the marrow results in suppression of hematopoiesis, right? So what is this?
Making blood.
Yeah, it's making blood, right? So we're going to see those cytopenias. So we're going to see anemia, decreased RBCs, decreased platelets, and decreased neutrophils, right? Key characteristic of ALL, I want you to think CNS involvement, right? CNS involvement. So these lymphoblasts may accumulate in extramedullary sites, meninges, right? Gonads. But I want you to think CNS involvement, right? What did I tell you the Philadelphia chromosome? What's the first thing I want you to think? CML. Now here's that asterisk next to it. You can also see it in some ALL subtypes, right? But the first thing I want you to think is Philadelphia chromosome is CML. It's going to be that T922, right? So that's synonymous with Philadelphia chromosome, T922. Right, so if you see either of those, think CML first, and then secondary, think ALL. It's less common, but you still can see it in some of the adult ALL cases, typically not with the pediatrics. Here's your Heme classification. Look at B cell and T cell, know the difference between those, right? And then less likely is the early T cell and the natural killer cell types. Remember, AML was the exact opposite of this, right? It peaked 68, this is peaking at 2 to 5 years old, right? But it still makes up about 20% of adult acute leukemias. Remember, ALL is kids, AML is adults. And like I said, with these acute leukemias are going to have abrupt onset of symptoms, right? And they're going to have a blast greater than 20%. So abrupt onset of symptoms may present insidiously, but it's due to marrow failure, right? So the cytopenias, fatigue, pallor, should be seen that in kids. Bleeding, bruising, right? So check those kids, do a full body exam, look at their legs, right? Kids like to get bruises, 1 or 2 is okay, but if you're starting to see them, if I see bruising, a lot of bruising on a kid, what's the first thing I'm probably thinking? Abuse, right? Then I get a CBC on them and I see their platelets are just significantly low. It may change my idea on that, right? But typically when I see bruises all over kids, I think some type of abuse. Fever from infection or from leukemia itself, which we're going to talk more about in the oncology emergencies too, as well as those fevers. Typically, understand this right here, the B cell and the T cell. So B cell, we're seeing those in large liver and spleen. T cell, the mediastinal mass, right? Make sure you understand that stuff. B cell, liver, spleen, T cell, mediastinal mass. So why would we see that mediastinal mass in the T cell? What?
Thymus.
Because it matures in the thymus, right? Where's the thymus?
And then you sign them.
All right, this is anatomy physiology, right?
Mhm.
CNS involvement. So understand that too, the ALS, I want you to correlate that. CNS involvement, if you have that pediatric patient, have a high index of suspicion that they may have ALL, right? Headaches, cranial nerve palsies, bone pain. What do we typically tell kids whenever they have bone pain? What do your parents tell you?
Growing pain.
Growing pains, right? I'm pretty sure I broke my leg at one point. My parents were like, it's growing pains. I was like, that's like, I'm not a doctor. I'm only 8 years old, but I'm pretty sure this is growing pains. My leg is bruised and swollen, but they were convinced it was growing pains. I just walked with limp for about 2 years, but no big deal, right? But limping, gait change, right? So think there's something going on with that. You're having that expansion of the marrow or infiltration into the periosteum, right? But B cell, T cells, understand those different masses, why they would generate in these places, that's CNS involvement, right? So that kid, pediatric patient is presenting as fatigued, they don't have as much energy, they look a little pale. They're saying like my legs hurt, I get this bone pain. And then they're saying I'm getting headaches. This is point you in that direction, right? You look at their legs, they have bruises all over. Or think of that stuff where the parents are like, hey, they're getting frequent infections, they're always sick, they're staying home from school, these may be cluing you in on stuff. But that may not be put together too, right? Because if you have a kid who doesn't have access, again, this is that social determinants of health, right? Look at your patient who's constantly going to urgent cares versus a pediatrician. Continuity of care, right? If you keep going to an urgent care or different urgent cares, or they're maybe a military brat that's PCS multiple times because their parents are constantly moving, they don't have great continuity of care. So you may be missing some of those pieces versus that patient that has a pediatrician for 10 years who has an idea of what's going on. CBC findings, again, we're going to see those cytopenias, decreased RBCs, platelets, WBCs may be variable. Lymphoblasts on the peripheral smear, right? And then hypercellular marrow, and then greater 20% blast, right? So acute process, we're thinking greater 20% blast. Right, if I say less than 5% blast on bone marrow biopsy, is that normal? If I say 5 to 19% and a 70-year-old, what are you thinking?
Chronic.
Thinking about one of those myelodysplastic, right? Or myeloproliferative diseases. Uric acid levels and LDH is increased because what? High turnover of those RBCs and those platelets, right? They're getting destroyed. And then cytogenic, so if I say T922, what is that?
Philadelphia.
Philadelphia chromosome. What else can you see that in? CML, right? And then flow cytometry too, to differentiate if it's B or T cell markers. Additional considerations, right? So we talked about it, CNS. CNS involvement is common. So put that together with that patient presentation. Common sanctuary for those leukemic cells requires prophylactic or pre-symptomatic therapy. Examination of CSF fluid is an essential diagnostic procedure. If you've ever had to see or have one of your kids or see it get done, nothing more heartbreaking than doing a lumbar puncture on a pediatric patient. I hated doing it when I was in the ER. Kids are crying, parents are crying, it's just not fun. But it's an essential requirement for ALS diagnosis. So, presence of a human blast is going to require intrathecal chemotherapy. So understand that, right? CSF is essential for ALL. You can see the presence of those blasts, you're going to require intrathecal chemotherapy. Now you're going to discover CNS involvement is going to lead to relapse. Multi-phase chemotherapy, again, is induction, consolidation, maintenance, up to 2-3 years, so it's not a quick onset. Intrathecal, that CNS prophylaxis is important, right? So understand that concept, that you know, that CNS evaluation, you may be missing something and they're going to be increased risk for relapse. Stem cell transplant is going to be considered for all high-risk adults. High prognosis or high cure rate in children, a little bit lower in adults. Again, it all depends on when you find it, availability of therapies, and any comorbidities that they have. There's a nice little breakdown comparison. It's pretty accurate things, right? So the blast, the rods, What else may you see in ALL? What type of abnormality? There you go, Philadelphia. From Elton John, right? There's another comparison. The LL, the lymphoblast, right? Greater than 20% on bone marrow biopsy. AML, it's myeloblast, right? It makes sense. Myeloid, lymphoid. And you see those rods, think AML. All right, so that is done for today. You guys got any questions for me? All right, so if you need to come see me,